Good afternoon, Dr. Towns.
Good afternoon.
To start off, could you tell me where you went to medical school?
Well, I went to medical school at the University of Rochester, and that was sort of an unusual arrangement. I actually was an instructor there in anatomy, and having received a PhD at the Art College Graduate School. And while working there teaching anatomy and embryology, which was my area of special interest, I was asked if I wanted to go to medical school on a part-time basis, free of charge, as a faculty person. So I did that, and I received my full salary and continued to teach, and went to medical school, and I found time to do it. I finally graduated in 1959, and then did take a 6-month internship in medicine and a 6-month internship in pediatrics, and returned to my teaching and the laboratory with no intention at the time of actually practicing medicine.
Okay. What did you choose as your specialty?
Well, in medicine,
Yes.
well, I ultimately became board certified in pediatrics, and I ultimately became board certified in medical genetics, but that was some years later.
And what made you choose medical genetics and pediatrics as your specialties?
Well, my PhD was in embryology, and so I had a particular interest in developmental phenomena, and as a result of that I had an interest in human reproduction, and that sort of led me to pediatrics. And my subsequent interest in genetics was largely triggered by my graduate studies for the PhD, where I took several courses in genetics. And genetics was just coming into its own at the time. For example, I took my PhD in 52, and that was at a time when people still thought that the human chromosome complement was 48 chromosomes. That's how little we knew about human genetics. And I actually learned it was 46 when a medical student told me that in the course of an embryology lecture, that this student just learned that the human complement was 46, published in the recent edition of Science. That triggered me into being somewhat interested in genetics, and it was a very interesting time because a few years later, in 56 or so, they first found that the human complement was 46, and in 59, Lejeune, the French worker, found that Down syndrome, or Mongolism it was then called, was caused by having an extra chromosome. So that really was a shattering, a real riveting discovery, and it caused a lot of people to become interested in genetics. And so I started to cook chromosomes, so to speak. I started to play with chromosomes in the laboratory around 1960, but a year after they discovered the story with Down syndrome. And within a short time, there were so few people doing chromosomes in those days that almost everything you looked at turned to be of interest. For example, trisomy 13 was discovered by a group in Wisconsin in 60, and in 62 I found the second case ever. That's how few people were really looking. And so it's very easy to do chromosomes in those days, or you could do it in a kitchen sink, really. And that sort of got me on my way. So I did a lot of chromosome studies, and finally, a couple of years later, opened up a chromosome service to the community. This was in Rochester again, and provided these chromosomes free of charge to all comers. And that was through a big state grant, which from New York State Department of Public Health, which paid all my expenses, paid me a small stipend, which they paid to the medical school. And we just saw anybody that needed chromosomes done. They were done free, and that went on for many, many years. New York State was quite interested in promoting that. and was very interested from a scientific point of view because a lot of new chromosomes were found in those days. Well, there were very few people doing it.
Okay. So, when did you actually start practicing in medicine?
Well, around I graduated from medical school in 1959. Around 1962, excuse me, I finally decided to start a genetic clinic.
Okay.
And that was, again, state-supported. No one ever had to pay to be seen, and the chromosome studies were provided when necessary. And that went on from about 62 till about, actually, to 1979, when I left Rochester to come to Massachusetts. And throughout that entire year, I never had to charge a patient for seeing them. We provided genetic counseling in a very comprehensive way, provided chromosomes, other studies that were done, and it was all free of charge. This was at a time when New York State was very interested in promoting the genetics, appreciating that it had some importance.
So could you describe your typical day when you started practicing medicine?
Well, my typical day in practicing medicine would I continued to do med teaching. That was my first responsibility. But I had several clinics a week at Rochester. And anyone who wanted to be seen would just call and make an appointment, and we would see them. And we usually had 2 or 3 clinics a week. And all of the patients were essentially, almost all were by referrals. And many of the referrals were from physicians in the community who had children with birth defects or congenital malformations or intellectual handicaps, or a lot of patients that were getting lost in the shuffle that a lot of doctors were really not dealing with. And they would send them to genetic clinic, and we would try to make a diagnosis if possible, at least check their chromosome status, and then most importantly, we felt, was provide something to the parents of the child as to what risks of recurrence there might be in a subsequent pregnancy. This was always a big factor. People who have a handicapped child or a child with a particular malformation are always interested in knowing, could this happen again? And that was a major service provided by a genetic clinic. So our day would be, we would see a small number of patients 2 or 3 times a week because the intakes were very long. So all patients were scheduled at hour intervals. And it would take an hour to take a good family history, and take an hour to examine the patient, and it would take a good deal of time to explain some elementary biology, namely Mendelian inheritance, to someone who may not have even had a high school education. So this was quite a challenge, but we were under no great pressures to get things done in a big hurry. And this went on, I would say, from about 62 to 79. I saw patients exclusively in a genetic clinic, and my other patients were hospital consultations. So if kids were born in the newborn nursery with spina bifida or cleft lip, cleft palate, or what have you, or Down syndrome, whatever, we got to see these kids, met with the parents while they were still in the nursery, try to explain them what the causes were and what the risks of recurrence might be, so that they could make future family planning in an informed way. So that basically was the thrust of the practice, was a very select population. It was a practice which was well received by the community docs because many of them had very limited knowledge of genetics. They had very limited basis for providing informed information, and they were very happy to get this off to somebody else who could provide this service.
So did your routine change at all over the years as you practiced medicine?
Well, it changed in that genetics gradually became, it was recognized to be an important aspect of medicine. And so it was more than now just doing the chromosomes. It was getting to deal with patients that had inborn errors of metabolism, and it was basically dealing with genetic disorders and the inheritance and so on, so that when I first started out doing this, there was only a single textbook of human genetics. It was a 2-volume book by a man named Gates, and that was sort of a collection of odd families. There wasn't even a, strictly speaking, a single human genetics text. And within the next few years, the text became available, and we were able to really deal with lots of previously unrecognized disorders, and it was sort of a bit of frontiersman. It was everything was so new disorders, new chromosome abnormalities, new inborn errors of metabolism. And all throughout all this, I had my own laboratory, and I picked up several new chromosome abnormalities, picked up a couple of new syndromes, Townes-Brock syndrome, which is still quite prevalent now, and trypsin deficiency diseases. And it was a golden era. There were few people working in this, and everything was there for just the pickings. In contrast to what it is now today, where there are zillions of people doing genetics in one form or another.
So, throughout your practice, you still continue to teach at the University of Rochester?
Well, I stayed at the University of Rochester until 1979. And in 1979, I was asked to come to UMass by then new chairman, Barry Hanshaw. And Barry Hanshaw was previously at Rochester, an old friend of mine, and he became the first chairman at UMass Pediatrics, and he brought with him a contingent of people from Rochester. They were known as the Rochester Mafia, and that included Peter Viles and Ed Sumter and Al Shiner and myself. They were all brought to Worcester by Barry Hanshaw, and all of these people are still in the community, except for Ed Sumter, who is in North Carolina now. And that was a wonderful times too, because we came to Worcester, big new building, lots of space. No one could imagine all that space ever being filled. There were just empty offices everywhere, empty labs everywhere. And the big story is, how are we ever going to fill it up? Of course, today, it's so overloaded that there isn't room to even move there anymore. But that was an exciting time, and we, the Worcester folks, sort of got invited to this genetics task force, which was a collection of the Boston Hospitals and Medical School geneticists, and when I first got here in '79, I was asked to join that group. And one of the big recommendations of that group was we needed a prenatal diagnosis laboratory in Worcester. There was none west of Boston in those days. There wasn't a single geneticist west of Boston except for me. And so I set up a prenatal diagnosis lab, which has continued to the present time. I set it up and directed it and ran it until I retired. It's now run by Dr. Jeswan, gosh, I've slipped his last name. Anyway, it's still at UMass, and still continues to provide chromosome analyses on amniocentesis samples and routine chromosome analyses.
Okay.
Oh, that was Dr. Jaswani is now the director of that laboratory. And my other major duty on coming to Worcester, besides setting up the prenatal diagnosis laboratory, was really, I was originally brought to teach the genetics course here at the medical school, and I had the similar responsibilities back at Rochester. I was in charge of the genetics course there. So coming here in '79, we had the teaching responsibilities again, the response to set up a genetic clinic and to set up a prenatal diagnosis and cytogenetics laboratory. And so my activities here were largely seeing patients referred to genetic clinic for genetic evaluation and genetic counseling, seeing patients referred by obstetrician gynecologist for amniocentesis analysis for prenatal diagnosis, and to generally provide genetic assistance to physicians in the community. Much of this was actually done over the telephone. A lot of it was done by providing consultations to their patients and providing genetic consultations to patients in hospital. And throughout that time, I tried to keep some of my research interests going.
So when did you stop practicing in Worcester?
When did I start?
Stop.
I stopped practicing officially, well, I became emeritus professor in 1995. And then I did continue to work until 98 as a part-timer, helping my successor, Dr. Demmer. And then since 98, I really have not been doing any practice. I'm really now fully retired.
So while you were practicing, what were your hours like?
My hours were very regular. Unlike many physicians, I did not have a lot of telephone calls in the evening or anything like that. So I worked at the hospital conventional hours. I was usually there 6 days a week because I like to be there on Saturdays when most people aren't there, because I could do some thinking and some writing, and so I was always there almost every Saturday. But I'd be there from 8:30 to 6 or so, and do that about 6 days a week. Have several clinics during the week, and the rest of the time teaching and trying to do a little research.
Okay. So how often did you work at the hospital?
I worked every day.
Okay. Yeah.
See, I never had a practice outside of the hospital. My clinical activities were, for all those years, at Rochester, or at the University of Rochester Medical Center Hospital, and here in Worcester at the University of Massachusetts Hospital. So I never had an office outside the departments, these two departments.
So where did most of your patients live?
Well, when I was in Rochester, we covered a very large geographic area from northern Pennsylvania to Lake Ontario in the north-south direction, and as far as Syracuse, which is 80 miles to the east, and about a similar distance to the west. So we had a very large part. I think we had about a 2 million catchment area, actually. And in those days, there were some people who couldn't really get to see a geneticist. So I had myself and a nurse practitioner. We went to various communities in western New York and brought genetics to them. And we worked in the public buildings, had our clinics there, and we had clinics in half a dozen different cities. I used to do a little bit of that here as well. I used to go out to Pittsfield once a month and try and do a clinic there. Then they finally got their own geneticists. I used to go out by Springfield, but they got their own geneticists. So there are so many more people involved now. When I first came here, there wasn't a geneticist west of 128, but now there are several.
So were your patients usually referred to you?
All were referred. We did do some self-referrals, but all patients were by referral, and all patients were seen for about an hour, and all who had a very lengthy evaluation with a very comprehensive consultation letter sent to each physician.
What do you think it was like for your family to have a physician in the household?
Well, it wasn't anything very unusual, because I was, unlike many physicians who have the patients calling home at night and so on, which does interface with the rest of the family, I really had very little of that. Here in Worcester, the only times I would ever get called would be if some baby born at the NICU or something like that, and there's an emergency there. They had to get diagnosis clarified. And so I would go out in the middle of the night, sometime 2, 3 o'clock in the morning if they ever called. But other than that, I had very little in terms of phone traffic at home at night, because most things weren't that urgent, and people usually wait until I get into the office during the day. We used to get we had a public telephone number so that anybody in Massachusetts could call and get genetic assistance, or couldn't call it really advice, but some sort of genetic assistance over the telephone. And we encouraged that. We had a brochure which we distributed, passing that number around so that anyone who really needed some information could call and hopefully get some, at least find out whether they need to be seen or not.
Did you have any vacations?
Oh, sure. I was never great on vacation, but because I used to usually take about 1 or 2 weeks a year. When I was in Rochester, we used to come to the Cape, and when I came here, we used to go to the Cape. So when I moved to Worcester, it was still, so that didn't change. I used to take 2 weeks a year.
So what ultimately made you decide to become a doctor after teaching for so
Well,
long?
it was sort of a strange evolution. I had my PhD, and I was teaching gross anatomy and at Rochester. This was back in the early 50s. And in terms of teaching gross anatomy, I kept finding, however, that there were lots of questions that medical students were asking which had medical application and which we didn't all have the answers for. So we would try to train ourselves to give them little clinical bits of information. Like when we were looking at the spine, we'd sort of point out where you did a lumbar puncture, and so we went through all this. But there was a lot of questions being asked, and I didn't feel quite comfortable with it. And then finally, after a couple, 2 or 3 years of that, the chairman of the anatomy department asked me if I'd like to go to medical school part-time and keep my job and get my regular job, but do it on a part-time basis. And this is at Rochester. And fortunately, I'd already had the biochemistry and physiology as a graduate student. So it turned out by going summers and fidgeting things around, I was able to, over about a 5-year period, to get a free medical education, and while earning my regular salary as an instructor of anatomy. And as I say, I wasn't planning to practice. I did take an internship, but I had no intention of practice. I just returned to my teaching job and stayed there. And then with the emergence of genetics and the setting up a cytogenetics laboratory, I found myself interfacing with doctors and patients to a greater and greater extent. And so finally I did start a genetic clinic and saw patients on a regular basis. I did go to England, did a fellowship there in genetics at the Galton Laboratory, which in those days was a very prestigious human genetics laboratory, and they sort of got a lot of reorientation about it from that. Came back and just did it. And nothing really changed. I still went to the same job every day. I still had my office in the anatomy department. I had a joint appointment in pediatrics and a joint appointment in obstetrics and gynecology because of my involvement with the prenatal diagnosis laboratory. But when I was in the pediatric department here and in OB/GYN, I was just like anybody else, except I had clinics and a laboratory.
Do you have a favorite memory from when you practiced?
A favorite memory from when I practiced? Well, I have one memory which was not a favorite, but I'll share it. When I was practicing, when I ran a genetic clinic in New York, as I mentioned, we never charged anybody. And about the last year I was there, they decided, the State Department of Health decided they were going to no longer provide free service, and they decided to change, and they were going to start charging. It was just about time I was ready to leave. And I got a frantic telephone call from a secretary one day, and she said that she warned me that there was an angry person maybe coming up to see me. And I said, about what? She said, well, he just took $50 worth of pennies and dumped it in my typewriter. And I said, what was that all about? Well, he got a $50 bill. I never handled any of the bills because the hospital handled all that, and they changed the rules, and this guy was not informed that the rules had been changed. And all he knew was his doc told him it was free, and when he got a $50 bill, he thought somebody was trying to rip him off. And so he got $50 worth of pennies, drove all the way into Rochester, and dumped it in the secretary's typewriter. That's not a very pleasant memory, but I thought it was sort of one that I do recall. I've had lots of pleasant memories. My best memories were when people were referred to me with a referral diagnosis of Down syndrome. And I had the pleasure of telling them that it wasn't Down syndrome. That was not an entirely rare event. Some people had very limited knowledge of Down syndrome, and if the baby came out looking a bit unusual and showed any developmental delay, they'd wait till kids about 8 or 9 months of age. They'd see if the developmental delay is apparent, and then they'd finally, because they didn't know any other specific type of developmental delay or mental retardation, they'd tell the parent, this is Down syndrome. And they'd say, what's that? That's Mongolism. And then they'd say, well, we got to prove, how do you do that? Well, he needs a chromosome now. So they'd send him to me, and then you'd take the kid be perfectly normal. And so you had the thrill of telling someone who for many months may have thought their child had Down syndrome when it didn't have Down syndrome. I think that's perhaps the closest thing to a really pleasant part of the extra pleasant part of an experience.
So when you first started your clinic, what were the most typical illnesses that you dealt with?
Well, the most typical ones were suspect chromosome abnormalities. And in those days, we saw lots of kids because they were born in the nursery. They might have trisomy 18 or trisomy 13 or Cri-du-Chat syndrome or a whole host of things. And these are all very interesting because the thing was to try and guess whether this was a chromosome abnormality or not, whether you could make an accurate assessment for it. And so we saw lots of very, very interesting patients, and we began to get a lot of individuals with very interesting genetic disorders which ran in families, which was only just beginning to get fully appreciated. So it was a time when you could make new discoveries because these genetic diseases had existed for years, and they'd get a family, they say, I have this, and my father's this, and his brother's got it, and 2 of his kids has got it, and so on and so on. And so it was a lot of interest and excitement in seeing new disorders, some not previously having been recognized, and actually putting labels on them.
Okay. How about in subsequent decades, what were the typical illnesses that you saw?
Well, the most common referral diagnosis that we saw was really developmental delay or mental retardation. If you had to find a single entity which was referred to genetic clinic, would be mental retardation or developmental delay. And the reason for that is because it's one of the most common diseases that there are. And so our job was to try, and the reason that it would be sent to clinic was because the parents of these youngsters would be badgering, rightfully so, badgering their doctors, is this going to happen again, or can this happen again if we have another child? And frequently the answer would be, no, it's about 1 chance in a million, it could never happen again, and it was just a sheer guess. Most of these people didn't know what the diagnosis was. So it was sort of a pleasant experience to be able to tell somebody who had a handicapped, severely handicapped child that that particular condition was not genetic and that their recurrence risk in a subsequent pregnancy was not significantly increased over the general population risk. And so this was, I think, a very gratifying aspect of that kind of a clinic. And so what you had was people who were greatly relieved, had been worrying about this for months, if not years, fearful of having another child simply because no one was able to tell them in an informed way that the risk was negligible. And a lot of the times, the doctors, including the OBs, would tell them the risk was high simply to cover their backside. They didn't know what it was, whether it was high or low or non-existent, but they would say high, figuring if it happens again, they're covered. Not being honest enough to say it isn't going to happen again because it's not genetic. So that was left to the more professional geneticists, and that was very worthwhile.
So what was the greatest challenge for you to treat when you started practicing in your clinic?
The greatest challenge?
Yes.
Oh, the real challenge was to do the very best you could for your patients. You would hope that your diagnosis was correct. You would hope that the advice you had given was accurate and applicable, and that you had filled their needs. And if you did all those things, they went home satisfied and you went home happy, feeling you'd done a good job.
And how about now? What do you think? Do you think there's any one illness that is a great challenge for a geneticist to treat?
Well, there are zillions of them, because what's happening now, in contrast to what it was in the 50s when I started, in the early 60s, everybody thought genetic diseases were exceedingly rare. No one ever knew anyone who ever had one. But if you read the New England Journal now, New England Journal of Medicine now, and if you look at any journal you pick up, you'll find they're riddled with genetically determined diseases. So genetics has become a very, very important feature of human disease. There's some people that feel that medicine is really a branch of genetics rather than genetics being something to serve medicine. And it's true, because if you think of things like even coronary artery disease or the atheroma plaquing of your arteries, you don't think of that as a genetic disease, but it's the human genes that are causing the atheromatous plaques there. And so it's not unreasonable to think that behind every disease, it's either genetically determined or genetically influenced to a great degree by some other genes in the genome. And so I think it's been gratifying to see that physicians have come to recognize that genetics is an important aspect of medicine, although I never dreamt it would be as important as it was. I've often thought that if I fell asleep 30 years ago and woke up today and saw what's happened with genetics, I wouldn't believe it. You would never believe it. But having lived through it and seen it evolve gradually, you do believe it. So I think that genetics is really now at the very heart of medicine in terms of diagnosis, treatment, and prevention.
So what was one of the most important breakthroughs in disease treatment during your career in medicine?
Oh, the great disease treatment, I think, nothing that I would have anything to do with, but the great disease treatment, I think, was something like elimination of polio would be, I think, one of the great accomplishments of a human medicine. I think that overcoming or greatly controlling infectious disease has been a major accomplishment of medicine. But the introduction of antibiotics in the late, such as penicillin, in the late 40s, and from then on with the sulfurs and so on, people are no longer dying of what they were dying of. And that's all because of the new insights into treatment of genetic disease. Unfortunately, many genetic diseases are not very easily treatable. I mean, people by the millions are still dying of sickle cell disease. We understand sickle cell disease down to the amino acid substitution and the globin, and the beta globin chain, but that doesn't mean you can cure it. So genetics has afforded great understanding and in many instances means of treatment. But unfortunately, treatment of many genetics diseases is not so readily apparent, although many companies are trying to do that. But there's no simple way to prevent have someone having an extra chromosome unless you do an amniocentesis during pregnancy, but that's after conception. Of course, some people don't find that such a very acceptable solution. But I don't know what the great diseases are. I don't know. I think I've lost my track of what your question was, but.
I'll just move on now. Could you describe attitudes towards smoking and cancer throughout?
Oh, yeah, well, I was a smoker. I think it's a terrible, terrible disease to be a smoker. And I think that I agree with all the literature which suggests that it's probably one of the one of the foremost killers of people in terms of shortening their longevity. It's interesting to see that smoking has come under so much control, and yet if you go down into see many young people, to see, I think, more women are smoking now than perhaps was in previous years. And everybody knows it's bad for you, but it's a terribly difficult habit to break. And I know I was a smoker and stopped about almost 20 years ago. But in those days, people smoking, they didn't know that it could conceivably be harmful. But the Surgeon General's report has been out for decades now, and people are still smoking. And it's unfortunate, and more so now with all the drug use. I mean, that's yet another problem. But fortunately, those are not genetic questions and so problems, and so I haven't had any first-hand involvement with them.
That's right. In terms of technology, what is something that doctors take for granted now that you didn't have?
Oh gosh, there's so many things. You see, you're talking to a very old practitioner. When I was a house officer, we did not have any plasticware for IV, for example. Literally. And so if you had to give a baby an IV, you have an open cylinder on a board, a glass cylinder, and you mix up the solutions, and you we used to cover the top with a sterile 2x2 to keep the dust and dirt from falling in. And then from that would be literally a piece of rubber tubing put on the end of a needle shoved in the well, today they have all these sterile disposable packs, which we never had in those days. That's the biggest difference, really. Everything is in terms of individual use and disposable needs. We used to have to, when I was a house officer, we used to collect all the syringes and put them in soapy water, and they'd have to wash them and cleanse them, and they'd take the needles, the Lurlock needles, and sharpen them down. They'd lay these good volunteers sharpening bevels on needles. Of course, today every needle is disposable. Every syringe is disposable. The disposable ware that we now have it's not so new. It's actually old, but compared to what it was 40 years ago, it's a big advance.
So So what technology is still being used in genetic labs today that you used when you practiced?
Did I use when?
That you used in the 60s when you
Well,
practiced?
I think the basic techniques of cytogenetics haven't changed all that much. They've improved the staining of the chromosomes dramatically. They used to look like just black blobs, and now they're high resolution banding. But the mode of culture of the cells in amniocentesis that we used 20 years ago are still being used today. The techniques for growing chromosomes that I used many years ago are still being used today. But after the growth, the handling and the staining and the harvesting is a lot better, and the preparations are a lot better. But the techniques are basically not that very different than they were in the early 60s. That's, you know, over 40 years ago.
Throughout the course of your career, did you witness any one significantly, any one significant invention in your field of genetics?
Any one significant invention?
Yes.
Did I notice any, or do I?
Well, did you witness any? Were you around for any great breakthroughs in technology?
Well, I think the gene sequencers that they now have are incredible, and that represents such that if you really fell asleep 10 years ago and woke up today, that's one of those things you'll never believe. What has done to the mapping of the human genome so precisely, almost every thousands of genes are now known to be precisely located. You know, 30 years ago or 40 years ago, they didn't know where any genes were on the chromosomes except the X chromosome, and that because the pattern of inheritance was different. But anything other than an X chromosome gene localization, there were none. And now we know with great precision where thousands of genes are. So that's been a tremendous accomplishment.
What would you like to see invented in the genetic lab
What would I like to see invented in a genetics?
now or in the future?
Gee, I don't know. I really have no idea what. I think they've invented so many things that they're able to do almost anything you can dream of doing these days. They can change genes, they can insert genes, they can take out genes, they can sequence your whole genome in a very short time. So they've really left very little that you can imagine. The biggest change that you would like to see, which is going to be a long time coming, is to completely eliminate a genetic disease. Take like cystic fibrosis. We know everything about the cystic fibrosis gene that you could ever want to know, but that still doesn't give you a handle on taking that gene out of that person, or better yet, replacing it with a normal gene. So the ultimate goal of human genetics, in terms of treatment of disease, will be to replace disease-related or deleterious genes by the normal homologue. How to do that? That's simple. That's probably the biggest challenge.
What were some of the most important drugs that you used in your practice? Did you use them?
I could tell you now that I probably haven't written more than 20 prescriptions in my lifetime.
Okay.
Because almost everybody that I saw professionally, the only time I would ever prescribe anything was when I did attending rounds at Rochester and at UMass. But as far as outpatient clinics patients were concerned, they referred to me to be an assistant consultation to the referring doc. And if I thought somebody would be benefiting from some medication, then I would tell the patient that, and I would have the doctor write the drug and prescribe, because he'll be seeing them and following them. I'm not going to put someone on a drug that I'm never going to see again. So most of the patients that I saw in the genetic clinic, I never had come back to me for anything, unless some problem developed and they wanted to. So if we thought they could make a diagnosis that indicated a specific drug, we'd line it up and have the home doc, the referring physician, take it from there. So I really prescribed anything.
How did patients without money get health care?
Well, for me, it was never a problem, because when I was at Rochester, I've never personally ever billed a patient, but my entire practice in Rochester was supported by a grant from the New York State Department of Health, and they paid the university part of my salary. They paid the university for me, my technician, to run my laboratory, and so we never charged the patients until I'm talking about that last year, where they finally decided to start charging, and that threw the pennies in the typewriter. But we never did that. And likewise here in Worcester, we did charge, but I was never involved in that. All we did was fill out a piece of paper, and that went to the big billing department, and we never saw anything in terms of whether the patients paid or didn't pay, or whether they paid completely or never paid or anything. Every now and then, individuals who were billed would indicate they couldn't afford to pay, and the university policy was always ask the physician if he would be willing to have the charge canceled. And of course, I always said yes, because it had nothing to do with me anyway.
So do you think that everyone who needed care in your genetic lab received it?
Well, I think that the care situation is pretty well handled in this day. The very really indigent people will have Medicaid, and those who are financially above the Medicaid level will probably be asked to pay, but I don't think that there are many people who are going really without medical care in this country. But there are many people who argue that this is still an imperfect system, and some people like to look at the Canadian example, where everybody more or less has a government-sponsored medical care program, so that there's no one left out. But in my practice in Rochester, I never had any bills sent to my patients for all those years, for 20-odd years.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Socialized medicine? Well, it's interesting you ask, because I remember when I was first getting into practice, that even preceded the Blue Cross Blue Shield and the HMO concept. And I remember when Blue Shield was just starting, all the physicians were worried that this was the end of medicine as they thought it. They thought, if you're going to have a big company paying for patients, that this is going to be socialized medicine, is what they called it. And of course, it never happened. And actually, it turned out to the financial advantage of these physicians, because with the development of Blue Shield, Blue Cross, and other similar health insurance companies, they ended up getting paid better than they did before they were developed, and they were developed in the 50s and 60s. Because when it was a direct payment, those people didn't have the money, they wouldn't pay anyway. So that the physicians surprisingly did better than with the development of these kinds. But the medically indigent in every state will be served by Medicaid, and the elderly is supported by Medicare, and I think that That was one of the attractions for me of being in an academic institution. Didn't have to send bills to patients and didn't have to worry about whether they're going to pay it or not, and if they don't pay it, how am I going to pay my nurse, and how am I going to put food on the table, and so on. Being a salaried person is maybe a cowardly way to approach medicine, but it does spare you a lot of the problems of the type that you're asking about right now.
So what would you like to see happen in terms of government and healthcare?
What would I like to see in terms of government with health care? Well, there's a real problem there, and I'm not sure what the balance is. The more that government gets into health care, the more people get concerned about intrusion into privacy and so on. And government is a big open forum where anything that gets in there becomes public knowledge. And that is something that has to be the privacy issue is a great concern. On the other hand, you would hope that having government provision of medical care, that at least it would reach everybody, including people who may now be having difficulty obtaining adequate care. So it's the problem. The problem is the balance between maintaining the privacy and yet making it available to everybody, and keeping Big Brother out of everybody's bedroom and so on.
When did HMOs first start to impact your practice?
Never really did, because I never really did need billing. So if it impacted me, I have no way of knowing, really, because I was not billing for 20-odd years in Rochester, and here I don't know. I have never sent a bill in my life to anybody, but my employer, the medical school, hospital, does. How they do it, when they do it, I really am cowardly enough to think I just haven't gotten involved in it. And I think that's one of the reasons why I've stayed in academic medicine, because I did not want to have to chase people for money who couldn't afford to pay for their medical care.
So you mentioned that you went to medical school for free,
Mm-hmm.
and that greatly helped your practice. But how much do you think it would have cost for you to go to medical school at the University of Rochester at that time?
Oh, I don't know. Probably, well, at today's dollars, it'd be probably around 50, I would guess.
How do you think, well, the cost today would compare with the cost back when?
Oh, I think it's probably more expensive today than it was then. Listen, when I was teaching as an instructor, well, put things in perspective. I don't know if I can share this with you, but my starting salary was $3,000 a year with a PhD. That was in 1952 at the University of Rochester. So, I'm sure there aren't many people with PhDs working for $3,000 a year today.
That's right.
So it's all relative. So if I told you that medical school was only $10,000 a year, then what does it mean?
Yeah.
$10,000 is probably the same as 45 or 50 now.
So do you think the cost of school, medical school, back in the 60s influenced how people practiced medicine at first?
Oh, sure. Absolutely.
Compared with today, though?
Well, I think that the actual cost of medical school, total cost now, is clearly reached. There are people coming out of medical school having $200,000 debt. Now, if you've got a $200,000 debt, I've forgotten, there are all kinds of examples, and you pay it off at, say, X amounts of money per year with the interest on it, you may never live long enough to pay it off. And so it's a horrendous bet. And that certainly has caused a lot of people to make selections for careers with short residency programs, simply because they can't spend another 7 years after medical school becoming a heart surgeon, because they're they'll never be able to pay off all their debts. So it does influence people greatly as to what sort of practice they will have, and it's become more and more expensive and more difficult for people to undertake long residency practice. So that's why a lot of people are going into practice earlier than they used to.
Before we move on to the final section, how do you think malpractice insurance has changed over the years?
Well, it's a devilish business because there are so many, frivolous suits with 6, 7 figure payouts that it's all too attractive. And if you listen to the radio, watch TV, or read the newspapers, there are people, does your child have a birth defect, or we can sue the doctor. One attorney, Sokolov, who advertised a great deal. You see, their trouble, the trouble with that system is that they can, a good lawyer can take a case like that and get a third of $10 million on one case. So he's going to work very hard on that. And the trouble is that if there's a sort of negativism on the part of the public at large, I think, about doctors being somewhat overly paid to begin with, and therefore they should pay back at time when it's malpractice. So malpractice settlements are outrageous, and the place to compare it to would be the Canadian system, in which they have very sharp limits as to how much you can sue for. And the limits are what would be reasonable. Someone I remember the most ludicrous one I ever heard of. Someone had a loose tooth. A kid with a deciduous tooth had a loose tooth in his mouth, and he underwent a tonsillectomy, adenoidectomy. And in the course of the tonsillectomy, adenoidectomy, the tooth was knocked off. They sued. Some people would pay the dentist to lift that tooth out of there and be happy it's out. But because that kid had a tooth and he lost it in the course of TNA, that's a reason to sue. Well, that's just an example of the psychology of suing doctors by some. That's not very many, but it's enough to make it a real problem.
Okay. Briefly, could you just comment on your experience practicing in the Worcester community and how it's changed and how it's been different from other places that you've practiced?
Well, I've only practiced 2 places, Rochester and Worcester. Worcester, I've seen a lot of change in Worcester since I've come here, and I think a lot of that change in the community, not so much in the practice, but in the community, is due to the development, the presence of the UMass Medical School. It's done a lot to, I think, to improve the medical care in the community. It's also done a lot to bring in many physicians into the community, a lot of more highly educated people, because UMass is really the #1 employer in Worcester County, and many of those employees are highly educated individuals. And so I think what has come from Worcester is, some people would describe it as sort of a mill town, but I think it's changed a great deal, and I think the biggest factor of changes is the medical school.
All right. Well, finally, do you have any advice for younger doctors just starting out in the field of medicine?
Yeah, do the very best you can for your patients.
All right.
And to take the time to do it.
Okay. And maybe in about 30 seconds, could you just comment on public perceptions of doctors when you started practicing as opposed to now?
Oh, I think the perception hasn't changed all that much. I think most people, I think physicians continue to be regarded as highly ethical, altruistic, good people. That's not to deny that every now and then you read about someone who has disgraced himself and the profession, but I think that all polls suggest that physicians are still highly rated by the public at large.
All right, thank you very much, Dr.
Thank you.
Jones.
Yeah. Ooh.